This is Scott Becker, the publisher of Becker's Healthcare, and I'm thrilled today to be on a podcast with Dr. Stephen Morgan of Carilion Clinic and Kim Lewis of Lenovo Health. We're talking today about empowering care collaboration in a virtual care world. We're going to focus today's discussion around requirements, information technology and otherwise, that are necessary for promoting collaboration in the virtual healthcare environment, i.e. in an environment where people are providing care, but not doing so in the same physical space as the patient themselves. We've got Dr. Steve Morgan, the Senior Vice President and Chief Medical Information Officer at Carilion Clinic, and Kim Lewis, a registered nurse by background and a clinical solutions manager at Lenovo Health. I'm thrilled to be joined by both of them. The subject of virtual care and telehealth is something that's been discussed and talked about for the last decade or so, but it's really the last couple of years where some of the largest institutions in the country have really taken telehealth and virtual care to a whole nother level. One major system reports that nearly 50% of all of its care is being delivered in some virtual way or another. With that type of bellwether of a system moving forward towards this, we see many other systems doing it for a variety of reasons. Many systems are doing it because of the cost containment ability in a risk-based environment. Other systems are doing it just for the simple ability to provide better care to patients that reside not so locally or so close to their main healthcare providers or who they'd like to see. It's also a way to extend specialties and extend specialists to more remote areas. It allows different professionals to collaborate together that also aren't in the same location. And finally, we see a lot of systems moving towards it just for the sheer fact that it's more convenient for patients. So from a cost savings perspective, care collaboration perspective, ability to see patients from remote area perspective, and just sheer convenience, we've seen really what can only be described as an explosion and acceleration of telehealth and virtual care. With that, Dr. Morgan, I'll turn it over to you to introduce yourself and just give us a few thoughts on some of the things that you're seeing to start with. And then Kim, I'll do the same thing with you.
Scott, thank you. Appreciate the opportunity to participate this morning. As Scott said, I'm the Chief Medical Information Officer for Carilion Clinic. We are an 8-hospital system located in Southwest Virginia and headquartered in Roanoke. We have 700 providers, and really our area that we cover is predominantly in a rural area. So we have a flagship hospital in Roanoke, but we have multiple outlying sites in a large portion of Southwest Virginia that I said is rural. So I would agree with Scott. For us, really, we are trying to provide better services and care and extend our services out into a large footprint in Southwest Virginia. So that includes extending some of our specialty services. We are part of a next generation ACO, so we are looking this as a way to do more cost containment. 2 years ago, we were really just getting started on telemedicine with some projects around teleradiology, and this really has exploded over the last year in our area to now including multiple projects.
Thank you, Dr. Morgan, for giving us your background and a couple starting thoughts on virtual collaboration. Kim, can you take a moment to introduce yourself and tell us a little bit of background on yourself?
Yes, thanks for the introduction. I am Kim Lewis, and I am a clinical solution manager for Lenovo Health. And my job really for Lenovo Health is to make sure that when we're creating solutions that speak to virtual care, that we are able to keep the patient in mind and keep the nurse in mind and keep the provider in mind and think about all the workflows and things that have to happen both in the office and in the patient's home to make sure that we have an offering that really speaks volumes and provides value.
Kim, thank you very much. What's some of your background before being with Lenovo? Just a moment on that.
So I worked at the bedside as a registered nurse for 8 years at various multi-academic medical centers here in North Carolina. And then I left the bedside to be consultant for KPMG for 3.5 years and found my way right to Lenovo.
Thank you very much. I'm going to ask each of you to describe a few examples of how you see care teams collaborating virtually.
Particularly with our next generation ACO, we're just starting to look at ways that our care coordinators and case managers can use either telephonic outreach or using video outreach or telemedicine outreach to coordinate care with our patients. So some of this is asynchronous using the electronic medical record. but we are doing more and more of this to be able to reach out to our patients that are part of our next generation ACO. And a lot of this involves not only closing gaps in care, but also teaching patients regarding chronic disease. Another area that we see collaboration is with postoperative care, where we have patients come to our flagship hospital for care, but then we would like to have them come back in for a post-op visit. We are now experimenting with doing those post-op visits remotely in their regional family medicine office, so they don't have to travel as far. We're coordinating the care that way with the family practitioner or their generalist who's taking care of them, along with the orthopedic surgeon who did the original surgery.
So a lot of it on follow-up care and also a good deal on initial care. Kim, yourself, a few examples of how care teams you see collaborating virtually.
Well, I think it's important to just call out. People have been doing this very well for a long time in the hospital when we talk about holistic care. And the challenge really when we're trying to do it in a virtual way is to make sure that we still have all those same resources available for the patient, because as Dr. Morgan mentioned, those chronic care patients are very high risk and high cost patients, because when they leave, if there's no follow-up to make sure that they're able to get out of the bed and they're able to go get their prescriptions refilled, that's a huge burden on the system overall, but also for patient outcomes and quality. So as you mentioned, we're seeing a lot of our clients that are helping patients receive their care virtually with teleclinic apps or portals that they're utilizing, either homegrown ones or ones that are specific to their EHR vendors.
Thank you. Steve and Kim, in the current healthcare landscape, what are the technology infrastructure components that you're seeing used by care collaboration teams for virtual care? How are some of these systems selected, and how are the innovations evaluated and integrated into technology infrastructure?
It's an excellent question, because when we looked at platforms, at least in Carillion Clinic's case, we really tried to leverage our electronic health record in being able to expand the virtual care. So a lot of the solutions that we chose initially, we wanted to make sure that they could integrate back into the EMR. Now, what we have found is we recognize that not every solution and clinical scenario that we are doing telephonically or through telemedicine can go back through the EMR. So we also had to look at software that had some flexibility, so that could be used both within the EMR and in some cases through an app on a smartphone that was outside the EMR to be able to meet the use cases. We've worked on that over the last 2 years and really have settled finally on one platform that we are using predominantly for our telemedicine program here at Carillion.
How did you evaluate that? What did you see that chose you to move to one platform, and how did you make that decision?
The key thing was really, in our case, looking at integration to the EMR, and we looked at that basic video platform and the flexibility to be able to do that. We are continually evaluating different solutions of telemedicine carts as a hardware. What type of carts do we need to meet specific solutions? And when we evaluate that, we're looking at trying to standardize and minimize variation with carts, and in some cases utilize existing technology like computers on wheels to be able to meet some of the standards that we're trying to place for the organization. And I have to admit, too, that as this field has exploded, we also are looking at cost and trying to do this efficiently and within a reasonable budget.
Kim, Lenovo Health is one of the best names in information technology. What are you seeing in terms of technology infrastructure and components, and how are these systems selected, implemented by customers that you see out there, big health systems and so forth?
I think that from an infrastructure standpoint, I believe there's still a lot of piecing together, as Dr. Morgan alluded to. Everyone's kind of trying to take the next step, but also utilize the current devices and hardware that they have. And I think that's, having devices that are always on and connected seems like an easy thing to do. But at the end of the day, a lot of organizations are still struggling with, Wi-Fi at the end of the hallway. Everybody knows which corner gets the best signal, right, for their devices. And I think that's something that we really all need to kind of take a look at before we implement all of these solutions that we want to extend the reach of our four walls. We really need to also make sure that we're in good shape from an infrastructure standpoint internally as well.
And Kim, let me ask you a follow-up question to that and start with you here, because you mentioned something that plays into this. How do technologies such as cloud, wireless networks, and mobility play into this care team collaboration? What are some of the things you see? Are there problems that you see? And you mentioned them a moment ago. Can you help us with that?
Yeah, cloud, wireless networks, and mobility are all integral moving parts to provide seamless, reliable, and that state-of-the-art virtual care that we need. Being able to have access to the actionable data, really, and make timely and informed interventions for patients is one of those guiding principles, I think, that is required in order to make virtual care successful. And there's no problem getting the data, I feel. I mean, there is an access problem most of the time to the data, but once that data is flowing, either in the EHR or from a patient's devices to the cloud to the provider, it's really a matter of trying to figure out what data we need to have an intervention for and how we can be alerted to that most efficiently without tying up our program coordinators and clinicians.
And Steve, a similar question. You've got this fascinating situation at the intersection of family medicine and health information technology and virtual care. What are you seeing in terms of the technologies and how do they play into this? Things like the cloud, wireless networks, mobility. How much of those issues and things that you're talking about day in, day out as you work on virtual care?
As Kim talked about, looking at your basic infrastructure and making sure that you have particularly the wireless platforms in place is critical. A lot of our offices, when we started this, we did not have the necessary bandwidth to be able to do some of our virtual visits, telemedicine, even some of the audio transmissions that we use for virtual medicine. So we had to go back and really look at our wireless infrastructure, look at our telco providers, be able to increase some of the bandwidth into some of the areas and to make sure that we had those components in place. We also needed to look at redundancy so that we haven't gotten to the point, but we anticipate we will get to the point as other health systems have, to where we'll be doing a lot of this of medicine. There's some estimations that 16 to 20% of primary care visits could be done virtually. That if you're doing that type of volume, you need to have the redundancy in the network so that if something were to happen, that you've got some backups. The other key, I think, is on supporting mobile platforms. Some of our offices' footprints don't allow for a cart to be there because they're small offices, and you need to have the mobility, and in order to do that, you're going to have secure and robust wireless network.
Let me ask you a follow-up question, Steve, and this is an issue that all of us deal with more and more. Cybersecurity and security issues involving patient data, not just really cybersecurity, but just generally privacy and so forth. What are some of the issues that you're dealing with on patient data, and how is that being addressed in the virtual environment?
It's a great question, Scott, and particularly when you look at the recent ransomware, and which has raised cybersecurity, but it's also raised in our organization security in general. One of the areas I will tell you, and personally, that I think we underestimated as we started to roll out telemedicine and have these discussions were really around regulatory components and compliance components that include security issues. So how can you make it easy to transmit information back and forth on a secure platform, making sure that as we did due diligence with each vendor, that we had the necessary security on our end, and if you're using a third-party vendor on their end. We've actually done some of our telemedicine with other regional universities or healthcare systems to provide specialty care that we don't provide here at Carillion. And so you end up having to do even more due diligence to make sure that on both ends, the connectivity is secure. And patients expect that, and certainly that's what we want to do as a health system, is to protect their information. But it is an area that we have our chief compliance officer, our privacy officer, all engaged on a steering committee for telemedicine to help advise us.
And Kim, a similar question. What are you seeing in terms of security of patient data, especially in the virtual care sector?
I think that it's almost the same concerns that everyone has with their devices and with the data that they have that's not virtual that they're putting out there. It's almost amplified a little bit because you're not face-to-face in the office with someone that has your papers and your documents and they're working on their tablet in front of their device. I think that it really comes down to education. I think this security blanket is huge, right? I mean, you're talking about education in the office for staff on how to do things in a more compliant and less risky way, and looking at the wrong things at the wrong time, or even the devices that they're using and the platforms that people are using to communicate. I mean, patients these days want to be connected to their providers, but using apps and certain things that are not encrypted or compliant, they're not the first thing they're thinking about. They kind of assume that if it's something that is on their phone or is on their device as a platform or as a piece of software, that it should be secure. And I think there's just more to come on this. I'm hoping, and I'm thinking that in light of the recent news events and everything that's been going on, I think that we'll see that this will be more ironed out as we move forward. But it's a worry on everyone's side, right? I mean, it's not just a patient concern. It's a provider concern as well, because they don't want anything to happen to anyone's data.
Certainly an evolving issue and a fascinating perspective on it, how it's an amplification of what we see in the offices already, just some different elements to it. And then Dr. Morgan mentioned the point about how it sort of started from a regulatory framework, but has become less a regulatory concern. Well, it's still a regulatory concern, and much more concern of just truly protecting the patient data from outside attacks and cybersecurity concerns and so forth, in a very different way than the commercial concerns that really gave rise to privacy issues in the first place. But let me move on to the next issue. And Kim, I'll start with you here. How does the IoT play a role in care team collaboration with patients?
Yeah, I think it's safe to say that IoT has officially exploded. I mean, specific to care team collaboration, we're seeing a lot of devices and apps that are specifically for integrating data and devices that are feeding data to appropriate people, and to Dr. Morgan's earlier point, to the EHRs, because that's what happens when we have a system that doesn't pull in all that data. We have to have a software solution that is going to be able to speak to sort of the middleware, is going to be able to deliver that plan of care, that visit information back to the EHR. I think additionally, IoT is making it easier for patients to be engaged, participate, and keep track of their own health and goals just from a consumer standpoint. And it's easier to see with IoT the impact of how behavior is going to change health for individuals as well as for the population. And in my opinion, IoT is the glue that is going to allow virtual care to be successful and reach more patients. It's really going to allow providers and care teams to extend their reach.
And Steve, any thoughts on this, on how IoT plays a role in care team collaboration?
Yeah, I totally agree with Kim's comments. You know, I think IoT will essentially, as she said, make it easier for patients to be engaged. And in our experience, you know, the more engaged patients, I mean, typically they are caring more about themselves and they're healthier patients in general. We are starting to get more and more requests to be able to try to integrate devices, whether that's wearables, whether it's, we actually looked at monitoring devices that could be put on refrigerators that could tell basically how many times the patient opened the refrigerator door, or monitors that would be monitoring sleep cycles, all of those things that can actually provide information that could be clinically relevant. And particularly with the millennials and newer generations of patients that are coming in, we recognize we've got to move into this space because they're already interconnected. They're already connected by multiple devices, and that's kind of an expectation that that generation will have. And it is providing a lot of very interesting and I think what will be very clinically relevant information once we start to aggregate and compile this, be able to do better predictive modeling for patients or be able to be more proactive in our care for patients.
And Steve, let me start with you on this next question. Key challenges, technology and otherwise, that providers are facing in collaborating for patient care. So technology gaps, 2 to 3 key challenges you see, and if and how those are being addressed.
It's been interesting to look at the different challenges that we have had regarding the way that we are doing telemedicine. One of the gaps that we are addressing in our rural areas, and we're actually in the process of doing a survey, is really looking at the broadband footprint for our regions, because we still have some areas where there is truly a gap in that technology, and we have been working both at the local level and state level to try to enhance these services. So it's, from the technology standpoint, that's one of the gaps that we recognize. Another area that we're just starting to look at challenges really that is not so much on the technology, but it's really on our providers accepting telemedicine and getting a comfort level with virtual visits. We've moved a lot in that space, but that's still remains for us somewhat of a challenge as we've tried to teach providers about benefits, the efficiencies, about telemedicine, but there still is a comfort level, particularly around liability, that we continue to do education on with our providers.
Kim, this is an area of expertise for Lenovo Health and yourself. Some of the key gaps in technology in providing collaborative care and how those are being addressed.
That's a great question. I'll tell you. So my biggest concern, right, is that we go into a client and we help them roll out a teleclinic solution for their patients, and we give them tablets, and we help them with their cart situation, and we do all those things. And then we expect for them to give their patient a tablet to take home with them, and the patient doesn't have any access to Wi-Fi or connectivity at all. We cannot forget to think about that it doesn't matter how much money we pour into these initiatives in an organization. If that money and that investment stays in the organization, we're in big trouble, because the whole point of it is to be able to reach the patient in their home or in their setting of care where they prefer to be cared for. So I think we've really got to think about how we can talk to officials in the areas where we're providing this care, especially in these rural areas, Dr. Morgan, to your point, where the broadband footprint is definitely a huge challenge that's experienced by multiple industries and not only just health. And then I think that you're right on, Dr. Morgan, when you talk about providers' acceptance of telemedicine. Unfortunately, and to your earlier point, I think a lot of consumers now that are looking for a teleclinic resource, they want to just download an app and see a doctor that can treat them because they called their provider and it's going to be 2 weeks before they can get in. I think that if we provide some education and help providers offer some teleclinic visits in conjunction with the work that they're already doing, then they'll see some of the efficiency and maybe have some more time to see more patients. I think there's a lot of value in the primary care providers offering that service to their own patients so that the patient's care isn't further siloed when they reach out to another teleclinic offering where the provider doesn't know anything about them, and it just kind of creates more siloed care. So I identify and agree with both of those key challenges. I think if we can resolve those two challenges, we'll be doing really well.
That's really helpful. Two of the key gaps you mentioned, and Dr. Morgan highlighted these as well. One was just the patient's ability to actually access telehealth in the right way, meaning are they set up for it? Do they have a tablet? Do they have the right wireless? Can they actually be on the receiving or the patient end of this and have the right technology? And then you also mentioned just trying to encourage providers to be more and more open to it, in part so they don't lose patients or leakage of patients to other places. Virtual care and measuring quality. How do you measure quality? Are there CMS regulations in this and star ratings on it? Supporting tech infrastructure play a role in measuring quality? How are you measuring quality as things move towards virtual?
Scott, excellent question, because there is that concern, particularly from the provider side, that the care that you can render virtually may not have the same quality. We're actually, this is a great question for us because we're currently looking at some of those key performance indicators, and we've really started out using CMS, essentially hospital-based measures, to look at, are we reducing readmission? So for our telepsych program, that was one of the areas that we looked at to see were we making a change in whether the patient was readmitted. We're also looking at, in that particular program, the volume of visits, and are we actually able to, by having more virtual availability for psychiatry, are we reducing overall visits? Another area that we've recently started to look at is patient satisfaction, because we get more and more requests for virtual care and trying to look at those metrics very closely. We are just now starting, again, with our next generation ACO and looking at some of those specific quality metrics as we start to roll out some of the virtual visits for our care coordinators and case managers. I think that into the future, we're probably going to need to get a little bit more granular in how the care is rendered, looking at maybe whether or not there was either underprescribing or overprescribing for patients from a virtual perspective. And if we, with the chronic care, did it make a difference in whether or not the treatment for diabetes meeting some of those basic quality metrics? I am not aware, and as far as star ratings, and there may be, but it's not something that we have looked at, We do have a waiver with our next generation ACO, which allows us a little bit more flexibility within that context to be able to do virtual visits.
So fascinating. It sounds like an evolving area. It sounds like you guys are on it in terms of trying to develop the key performance indicators and what you're looking at. You mentioned a few of them on is it leading to more or less follow-up visits. You're starting to measure patient satisfaction with it and a number of other things. And also for your ACO, you've got a specific waiver to allow more telehealth and virtual care. Fascinating. Kim, some thoughts on the same question. How do you see people measuring quality in telehealth or virtual care and technology to support that or to make sure virtual care is, from a patient's perspective, going great and you're able to measure quality in it?
I'm of the opinion that virtual care offerings and these supporting programs are really born out of necessity, specifically the chronic care patients that we see come back time and again because they have gone home and they haven't been able to get their prescription or they aren't taking it the correct way or they're not taking their blood sugars. I think that providers and payers are struggling with the financial impact that those readmissions and delayed interventions really are having. And by utilizing virtual care, and that could mean, we've spoke about it, doesn't necessarily mean you're treating someone. It just means that you're connecting with them, right, to make sure that they are following their care plan and their journey that their providers have created for them. Really, we've been kind of looking to CMS to kind of help us pull out some of these guidelines, and right now we have some really clear ones for chronic care management where providers can bill for those virtual care visits that would be with a program manager or chronic care manager within the office. I think that, as Dr. Morgan alluded to, being able to have some very clear metrics and being more granular and looking at the data in retrospect will help us with some of the predictive things that we need to know.
Each of you are right at the middle of this movement towards virtual care. And what are 2 to 3 things that you expect to happen with virtual care over the next 3 to 5 years?
But one of the things that I am hoping for, and I think will happen, is that federal, state, and local policies, and particularly coverage by different insurers, will start to catch up to where the market is, because we still have struggles in getting appropriate payment for this type of visit. So I really think that will move forward and has to move forward for systems to be able to utilize what I think is a great technology to provide care in a better setting, and I think of equal quality. I think we are just scratching the surface on the way we could utilize devices. Again, if you go back to, that 20% of primary care visits could be done virtually, I'm thinking once you start to integrate being able to look at blood monitoring, looking at different wearables, that information could be transmitted virtually. And, I could be managing a patient or the team could be managing a patient. Essentially, they may only have to come in once a year where they were coming in 3 or 4 times a year because they'll now have access to that information. And it's, that's coming, that we'll be able to get that information from a smartphone, that we'll be able to treat the chronic care patients by utilizing that technology. Those personalized devices to be able to collect that information, I see that as exploding, and we're trying to anticipate where that's going to go next.
So really 2 core comments I heard you make. One is on the regulatory and reimbursement environment, having those accelerate so that more and more patients can be seen, particularly in a fee-for-service environment, and actually get reimbursed, and have health systems embrace it both in the fee-for-service and risk-based environment. And then regulatory. I know in some states it's still very difficult to do virtual care. In other states it's easier, and seeing more of a federal, where the states all getting on the same page on what's allowed. 2 fascinating comments. And then finally, third, just as the wearables and devices that patients have become more and more accessible, the ability that, if you said that today the judgment is 20% of primary care visits could be done by virtual health, the reality is that that might be able to move to 50, 60, 70% as technology becomes more proficient and more interconnected and usable for all these types of things. Fascinating. Kim, same question. What do you see over the next few years in telehealth and virtual care?
I think that the technology is just going to explode, and we're going to have to be able to pick and choose what we want, right? I mean, I can imagine that there's sensors in everyone's homes that are at risk for falls, and that people's homes will be connected to their personalized care journey. So they'll get reminders when they walk by a tablet or a speaker or a refrigerator to say, you didn't take your medication yet this morning. And I think that that's where we have to go, right? Because we have all these devices. We have such an opportunity to make them integrated into the patient's overall health so that devices that they're using already for music and for their refrigerator and for browsing and shopping on Amazon and everything else, that we're able to utilize that same technology to say, don't forget to take your blood sugar this morning, or you haven't reported a weight today. Just specific to the patient's needs and specific to the patient's orders that they have from their provider. That's what I'm hoping to see in the next few years.
Again, just great acceleration in it. The technology seems to be there, and it's more and more moving that technology to collaborate together, like the care teams are collaborating together. I want to thank Dr. Morgan and Kim Lewis for participating today in this podcast about virtual care collaboration. It's something that we've seen great acceleration in over really the last couple of years after what I think of as 10 years of talking about it. And some of the fascinating comments Kim made, Dr. Morgan made, thoughts about this is born out of necessity and just making patient care better as it is out of anything else. And then you also see sort of the financial modeling of this, where in some places the reimbursement hasn't kept up with it. In other places where people are at risk, it makes abundant sense for a provider and insurance plan to be looking at telehealth, and that's in fact where some of the quickest movement has happened. Some of the other comments on healthcare technology and being able to fix the gaps in this, and what's amazing to me is how much attention is being paid to it by people like Dr. Morgan as a Chief Medical Information Officer, particularly in a system that spans a wide rural area where you deal with very real problems of technology gaps, and then Kim Lewis and Lenovo Health, and the amount of insight they have into some things that seem just like very common sense, but require lots and lots of attention. Things like there being spots in the health system where the Wi-Fi doesn't work well, or where a patient doesn't have great access to stuff. It's always a pleasure to visit with the both of you, leaders in this field, and we are so appreciative. Thank you, Steve. Thank you, Kim, and we'll wrap up with that. Thank you very much.